Listen to Today with Sean O'Rourke with the RTE Radio Player.
For 2 days in a row this week, there were 760 patients waiting for hospital beds across the country. Meanwhile, hospital overcrowding has reduced somewhat today, according to figures from the HSE. It says there are 421 patients waiting for admission to a hospital bed. The INMO says 621 patients are on trolleys in Ireland's hospitals this morning. The worst affected ones being the Mater in St Vincent's in Dublin, Galway University Hospital, Cork University Hospital and Waterford University Hospital. On the line now, Fergal Hickey, consultant in emergency medicine at Sligo University Hospital, and Conor Deasy, a consultant in emergency medicine at Cork University Hospital. Conor Deasy, you are on the wards today, or you're in the emergency department. What is the story as you're seeing it?
Yeah, so look, it is very congested still. We've experienced unprecedented overcrowding over the last number of days, but it's coming on the back of a real uplift in overcrowding that we've seen essentially all during the year. I was highlighting overcrowding issues here at CUH on the 7th of July. So when you're going into winter, with that level of overcrowding, it is only going to get worse, and that is exactly what we've seen.
Because we're seeing now today, as I say, a fall in the numbers. The INMO, the Irish Nurses and Midwives Organisation, saying 621 patients waiting for admission. It says extra bed capacity sourced from the private and voluntary sector has contributed to the improvement on this week's record highs, but still they're higher than any day in January of last year. So how do you account for the steady increase?
Well, certainly what we saw happen back around May is that the services were, there was a ceiling put on spend. There was a reduction in the availability of home care packages as a result of that, a reduction in the availability of community hospital beds. And so we saw the hospitals' length of stay for patients that could not be discharged safely, not of any fault of their own, but who could not be discharged to their homes because of lack of home care packages. We saw that blow out back around the summertime, and that really hasn't improved. And then you put winter in on top of that, and it's only natural what would then occur as a result. And so we're seeing the ICU today under tremendous pressure. We're seeing the wards around across the hospital with extra beds up, and we're seeing the emergency department work flat out, and we're seeing ambulance offload delays and National Ambulance Service paramedics having to mind the patient while they're waiting space to offload the patient into the emergency department.
You are quoted in the Irish Examiner today as saying, "I haven't witnessed the likes of this when I've worked in the third world. These are third world conditions." Are you being a bit exaggerating or hyperbolic in that?
I don't think I am, Sean. I think in terms of what we're seeing on the corridor, we're seeing patients that are head to toe lined up on the corridor on trolleys. These are frail elderly patients who are in their 80s, who are in the worst stage of their journey to recovery, in that they're in the acute stage. They're in the first 8 to 12 hours of their recovery journey. And we know that that corridor medicine is dangerous. We know that treating patients in overcrowded emergency departments has a fatality associated with it, has a mortality associated with it. So I've been at a conference recently where that mortality is stated as being that for every 30 patients that spend greater than 8 hours in the emergency department, we have a death. Okay, so they're stark figures, and I certainly would not want the public to think that this should be accepted as being normal, and I would want the public to challenge their politicians on this and say that we as a people will not accept this for our older people, for our frail elderly. They deserve better.
If I can turn to you, Fergal Hickey, a consultant in emergency medicine at Sligo University Hospital. The IHCA, the Consultants Association, called for a national emergency to be declared yesterday, but we had a national emergency declared. It was in 2004 when Mary Harney was minister, and the numbers were half what they're at now. What difference would declaring an emergency make?
Well, I presume what was intended would be that you would get the response that emergency would justify. I mean, as you say, we've been there before. It was March 2006 when Mary Harney set up the first emergency department task force that she declared a national emergency. Interestingly, there was some political focus on it for a period of time, and the situation improved, and then it's gone progressively off the rails. And we've had a succession of ministers promising the Irish people that this will never be repeated and the numbers will never be exceeded, and yes, we've exceeded them consistently. As Conor has rightly said, this has been incredibly predictable. And the only thing that is saving us from far worse situations now is the fact that no elective surgery essentially is taking place. So what this proves is that at the best of times, and we have set new records all through the autumn, at the best of times we don't seem to be capable of providing elective services and emergency services simultaneously because of capacity problems. And even when around the Christmas New Year period, when surgical activity is essentially parked, and all we're seeing is emergency activity, we can see the extent to which the system falls over. This is incredibly predictable.
Yes. On the other hand, we hear it frequently suggested that many patients attending emergency departments do not need to be there. Now, are these types of patients affecting the rise in trolley numbers that we see currently?
Sean, unfortunately, we hear lots of absolute and unadulterated nonsense spoken about this issue. So the people who don't need to be there, if you come with a problem that turns out to be trivial, you do not end up on a trolley. You get sent home. And there's a lot of evidence to show, a lot of international evidence to show. There's a huge study from Ontario that shows that patients with minor injury or minor illness, the contribution they make to delays in emergency departments is very small, perhaps surprisingly small. So this is an often repeated bit of nonsense that people trot out as if by removing those patients that in some way will solve
Okay, well, maybe there's another
patients who require hospital admission, remember.
There might be another category of patient. Just looking at the text line here, Sean, an example of our health service. My 85-year-old dad has had a nasty cold for the last 10 days. We've been managing it with paracetamol, hot drinks, etc., etc. Today he is chesty, so I looked for a GP appointment. The GP has no availability left for this week. I can try to ring at 8 a.m. on Monday to try my luck for next week. And we wonder why people end up in hospital ED departments as emergencies.
And it's absolutely true there's a shortage of capacity both in primary care, and it's a worsening problem in primary care as it is a worsening problem in secondary care. Now, having said that, for an 85-year-old person to be chesty for an extended period of time, and in spite of the normal interventions not to be getting better, there is a chance that this person will be referred to hospital anyway by their GP. But we don't admit all the patients we see, far from it. We admit approximately 25% of the patients we see. And at this time of the year, the figure probably goes up to about 30% because of the cohort of patients we see. So it's not as if a patient coming to hospital, it's inevitable that they'll be admitted and it's inevitable they'll end up in a trolley. That simply isn't the case.
Conor Deasy, to come back to you in Cork, we know, for instance, the Minister has said there will be 199 extra beds, acute hospital beds provided this month, 50 of them opened by yesterday. Now, how significant a contribution might those extra beds make?
Look, so every extra bed is very important to us and is gold. But at the same time, in order to see a resolution to this, you're talking about a considerable number of beds. So for CUH, for example, we need 70 new medical beds, and they need to be funded, and we need to go away and recruit the staff. We can't, for example, just go out and employ the necessary number of staff and have them available tomorrow to staff these beds. There's a recruitment process around getting those staff in. There's also an infrastructural challenge in terms of creating that physical bed. And so if we're not to be having this conversation next year, Sean, we need the Minister to say, turn on those 70 beds at Cork and do it as quickly as you can.
And what are you saying to your patients there? I mean, you insist you're not exaggerating when you describe it as third world conditions. So what do you say to the patients who are in those beds end to end?
Look, Sean, it's heartbreaking for us as staff to have to deliver care and to continue to deliver compassionate care, professional care, effective care in this type of environment. We're apologetic to our patients. We do the best we can. We try and keep as good-humoured we can despite the challenges. But deep in our souls, we recognise that this is wrong and it should not be allowed to continue, and somebody has to shout stop.
And that's clearly what you're contributing to doing and saying yourself at this stage. But again, people look at the health budget. It's now up to, what is it, 16 billion euro for this year, going up by almost a billion every year. And yet we have these conversations only based on bigger numbers on trolleys year in, year out.
But that conversation around health budget, Sean, seems to happen in isolation. In the same conversation, one needs to acknowledge that there's been a 6.5% increase in the number of over 75-year-olds that present to our emergency departments. And 6.5% in and of itself doesn't sound like a big percentage, but these are patients that have complex medical and social needs that, if they do get admitted to hospital, end up spending at least twice as long and often are not capable of being discharged from the hospital back to their homes or back to the community, and need placement in community hospitals and in nursing homes and so forth. And that is associated with cost. Despite the cost, though, we cannot continue to allow our frail elderly be dealt with in the way in which we are dealing with them, which is on a corridor, on a trolley, where they're being sleep deprived because of light and noise and other patients. It's not dignified, it's certainly not safe, and it has a mortality associated with it.
Fergal, Hickey, given that there is an improvement today in the numbers, have we hit rock bottom and are we coming out of that now?
I'd be very careful about describing what's happened today as an improvement. As one of my colleagues described, there's no such thing as being half pregnant. You're either pregnant or you're not. So we're either crowded, overcrowded in our case, or we're not. Like, 1 is the only acceptable, we need to get below 1 as a figure. So when we're talking about figures like 400, 500, 600, 700, we're missing the point completely. As Conor has said, there's hard evidence to show that this kills people. There's also a possibility that we'll get a second bout of flu. So, for example, it's not unusual for there to be one significant period of flu, and then a further one comes later. And I would strongly encourage those that are in the at-risk groups to be immunised. But just on the issue of cost, I think that this is really important to understand. What the evidence shows is that our current spend on health is high. That's a fact. But we spend it in a lot of the wrong places. We spend it in propping up non-viable services and non-viable units around the country. We also end up costing ourselves money by the inefficiencies in the system. So if you're, for example, over 75 and you're on a trolley for more than 12 hours, your chances of returning to the level of function that applied at the time that you came in is actually significantly reduced. So these are people who end up ultimately going on to long-term care, which costs us a lot more money. If you end up coming in with a condition which is time critical and there's a delay in your treatment, then you're much more likely to have medical complications on an ongoing basis, which in turn costs money. So the fact that we don't invest in the places we need to invest, that we've historically underinvested in capital projects, capital infrastructure, means that we're reaping the rewards, if you want to call it that, of it. So we end up spending far more money than we need to, propping up an ailing system for the want of decent investment in the place that it needs to have happened in. And that's both in primary care, but also in secondary care. It's not a question of one or the other, it's both. But we haven't done either particularly well.
My thanks to indeed to both of you, Dr. Fergal Hickey and Dr. Conor Deasy, consultants in emergency medicine in Sligo and Cork respectively. Last word on this to a listener who says the staff at CUH A&E couldn't be compensated for the conditions they work in. I was in with an elderly patient who was in the A&E from Friday evening until she got a bed on Monday. The staff were fantastic. Every minister who gets a pay rise should hang their heads in shame in taking money when the health service is the way it is. You don't realise it until you're in there.
Today with Sean O'Rourke on RTE Radio 1.